Ruby. It's a pleasure to be here. Thank you to everyone for joining. So I'll begin by just introducing our four panelists this evening. We're very privileged to be joined by quite a prestigious panel. Professor Jason Leitch of NHS Strategy Scotland. He's a clinical director of healthcare and strategy for the Scottish Government, and he's had that post since 2015. He's responsible for quality in the health and social care system and has worked for the Scottish Government in other areas since 2007. Professor Leitch is also an honorary professor at the University of Dundee. We're also joined by Michael Livingston. He's the Deputy Director of the COVID-19 Taskforce at the Cabinet Office, responsible for regulation strategy, legal issues and social contact policy in this task force, which is coordinating the UK government's response to COVID-19. He's been directly advising the Prime Minister on these issues and leading their implementation across government. Michael has been a political advisor since 2006, including to members of the House of Lords, Ofsted, the Home Office and the Foreign Office. Our third panelist is Professor David Katz. He is an emeritus professor of immunopathology at the University College London. He spent his career researching dendritic cells, which I had to look up. These are known as the sentinels of the immune system, which identify new invaders and induce an immune response to them. Professor Katz is also the editor of the International Journal of Experimental Pathology and the co-deputy chair of the British Medical Association's Medical Academic Staff Committee. Finally, but not by no means least, local to me is Professor Eyal Leshem, who's near me in Tel Aviv. He's a clinical associate professor at the Tel Aviv University School of Medicine and the director of the Center for Travel Medicine and Tropical Diseases at the Sheba Medical Center, which is Israel's largest hospital. Professor Leshem has led and co-authored over 70 publications on vaccine-preventable diseases, tropical and travel medicine. He's also a guest researcher at the American CDC, the Center for Disease Control and Prevention, and a consultant to the World Health Organization. So that's your very prestigious panel, which we'll be hearing from shortly. But before we do so, I'm going to give a short presentation, just looking at some comparisons between how the coronavirus epidemic has been experienced and dealt with in the UK and Israel. Just going to share my screen here. Okay, so let's look at some statistics comparing the UK and Israel. These two countries have quite a lot in common. Although they have different populations, they're both very dense countries relative to other countries in the world in terms of population per square kilometer. They're both very heavily urbanized. By far, most people live in towns and cities, and they have similar levels of adult obesity. They also have a similar number of hospital beds per capita. So broadly speaking, by many parameters, we would expect the UK and Israel to have experienced the epidemic in a similar way. However, if we look at the number of deaths so far attributed to the coronavirus per capita, the UK has had a far worse time of it than Israel has, about 3 times as many deaths per capita as Israel. And it's interesting to think about what some of the causes of this might be. So this chart shows over time the number of deaths per million people per week in the UK and Israel. And you can see the blue curve here shows the UK and the orange curve shows Israel. So this kind of demonstrates on a graph the summary number that I showed previously, whereby you can see that the UK has had a far higher number of deaths than Israel per capita. One of the most key differences between the two countries is that very, very early on, Israel had a kind of national lockdown extremely early in the curve of growth of COVID-19 cases. And the UK did it in terms of time, not much later, but in terms of the number of cases at a much, much higher number. And this, obviously, you can see the consequences of this. Israel didn't really have a significant first wave of coronavirus. Of course, later on, it did have significant second and third waves, but the first wave in Israel was kind of cut short very, very soon. And I think maybe one of the most interesting and straightforward explanations for this is that Israel is a country which is quite familiar with crises and responding quickly to crises. And so the concept that we would do something very radical to our society in response to a crisis is something that the Israeli society and the Israeli government is kind of more used to than the UK was or many other countries. And that's perhaps one reason why Israel reacted so quickly. Another key reason, I think, is if you look at the population structure of the two countries. So Israel has a significantly younger population. It has 16% of its population above the age of 60 compared to 24% of the population in the UK. And as we of course know, coronavirus is far more dangerous for people above the age of 60 than for younger people. And that is, I think, part of the explanation as well. Israel does have an interesting and very problematic phenomenon, which I do not believe exists in the UK, and that is that it has two significant minority populations, which have a different culture to the majority, and which also live in very close quarters with people of their own subculture. And I'm talking here about the ultra-Orthodox population, which is about 12% of Israel's population, and the Arab population, which is about 20% of Israel's population. And as a result of this, we had almost different epidemics taking place in the ultra-Orthodox population, in the Arab population, and in Israel as a whole. And you can see some of this by looking at this graph, which shows you the number of active cases per capita in these two subpopulations compared to Israel as a whole. This created a very significant political and cultural challenge, because one of the natural responses to an epidemic is to make restrictions which are related to the localities in which the epidemic is most intense. So it's natural to say, well, if there's a lot of cases in one area, then we'll have stronger restrictions in that area. And if another area is okay, then we'll have fewer restrictions there. This is very difficult to do when those areas also map to clear subpopulations who are going to feel that they're also being targeted, not just because of their level of disease, but also because of something about their identity. And so this was a particular challenge which I think the UK had. Something interesting happened in kind of December 2020, which is the ultra-Orthodox population wasn't showing any growth in cases, whereas Israel as a whole and the Arab population was showing growth. And then very suddenly, the ultra-Orthodox population had an explosive growth in coronavirus cases again. And at the time this was happening, it was a little bit mysterious, because it looked like they had some kind of significant level of immunity, and then suddenly they didn't. And we discovered in retrospect that this was when the British variant was taking hold in Israel. It kind of very quickly rose to dominance over a period of maybe 1 or 2 months. So perhaps that's part of the explanation of why we saw that strange pattern. Nonetheless, the overall issue is that we have different patterns in different populations, and that creates a very specific challenge that exists in Israel, and I don't believe exists in the UK. One of the things that the UK and Israel have in common is that they are, global leaders in the vaccination program. Israel likes to think it has vaccinated the most people per capita of any country, but actually Gibraltar is ahead of us, but Gibraltar also has a population of a few tens of thousands. So in terms of medium-sized countries, Israel is very far ahead. And in terms of larger countries, the UK is also far ahead. So that's something very positive that's happening in both of these countries at the same time. And just one last interesting thing to note is that the coronavirus epidemic took place against a very specific political context, both in the UK and in Israel. And in both cases, you had governments that had kind of very specific things that they wanted to prove and things that they were thinking about that might have interfered with how they were relating to the pandemic. In the UK, of course, this was Brexit, which may have informed policy and may have informed also some of the issues relating to vaccines. And Israel, the political context was at the beginning of the coronavirus epidemic, the third election, and now that we are a year in, the fourth election, and probably soon enough a fifth election. So this these rolling political crises that were going on at the same time may have had some effect on government policies. So thank you very much. You've heard enough from me. I'm going to now return to our panelists and give each one the opportunity to give a brief introduction before we then move to questions. So if I can start, please, with Professor Jason Leitch from Scottish Government.
Thank you, Gideon, and hi everybody. Good evening. Thank you so much for having me. It's a real privilege to be given the floor briefly. I'm going to share some slides in a moment or two, but let me just underline my fake credibility for coming to speak to you, perhaps. So firstly, I'm the Scottish Government's guy, and I apologise for being on your TVs and radios a little bit too often. I'm sure you're as fed up. The only person still listening is my mother. If any of you are still listening, I'll be delighted to hear it. Apart from my Scottish Government job, and you may have heard this in interviews if you've paid any attention, is I have a real foothold in Israel. I'm on the board of the hospital in Nazareth, a relatively famous hospital in Scottish healthcare. There are very few groups that I meet, and I say I'm in the Nazareth hospital, and they've all been. Everybody has done an elective or done a moment or done a week in that hospital. We don't like it being called the English hospital, which is what the Nazarenes call it. We like it being called the Scottish hospital. And that's also why I wish I had known Gideon's slides, because I would have shown you Scottish mortality superimposed over Israeli and UK mortality. And you would have seen that it was lower throughout the pandemic. It is right now not lower. And all the 4 countries have now aligned around the same point, and the Northern Irish are actually having the best of the mortality presently, and the Welsh are having the best of the case rate. However, nobody is doing well. None of the world is doing well. It's misery, and it's misery almost everywhere. So let me put that in perspective briefly for you, if I can get to here and then here. And I'll do this relatively quickly so you can hear from other people. So this is a fascinating article from the Science Journal, still exists today, 100 years old. This is from May the 30th, 1919, the last time there was a global pandemic. And the definition of a pandemic is an infectious agent that risks every single member of the world. Every single person in the world is at risk. The WHO have never declared a global pandemic because they didn't exist in 1919. This is the first global pandemic of the modern era. And this paragraph, I won't read it all out to you, but you could write it in today's newspaper. The pandemic which has just swept around the world has been without precedent. There have been deadly epidemics, but they have been more circumscribed. There have been epidemics almost as widespread, but they have been less deadly. And this is where we are globally. These are the 6 global public health emergencies of the modern era. The WHO declare these. This is a lower bar than the pandemic bar. And SARS-CoV-2 on Hogmanay 2019 was declared a global public health emergency. It has now killed 2.5 million people globally. 1 million Europeans caught the virus in the last 7 days. 1 million. It is entirely without precedent in the modern era. If you haven't understood that, you have misunderstood. I Googled, did we shut schools during the war? Because I was about to give advice to close the schools. And we didn't close schools in the war. We moved them and we adapted, but we never closed them. This time, we closed the schools and we stopped screening for cancer for 3 months to allow us to treble intensive care units with doctors and nurses and resources. This is the present position in Scotland. This is the 7-day per 100,000 rate. We're just below 100, heading towards, we hope, 50, which is where the WHO say you need to be able to declare any level of control, and then below 20 when you can start to really think you have managed your next crisis. You can see how slow that downward curve is. It goes up fast, it comes down slow, and it comes down slow because of this. The red line, this is my only complicated graph, so stick with me. The red line is old variant, the green line is new variant, what we call in the UK, the Kent variant, what Gideon called in Israel the British variant, which we don't like, Gideon, of course. It's the Kent variant. That's where it was first identified. It may not be where it first mutated. It may well have mutated in another country, but we have the best genomic sequencing in the world, and we found it. And you can see the old variant plummets quickly. So lockdowns work for the old variant. They work for the new variant, the green line, but they work much, much more slowly, significantly more slowly. And that's why the Scots here are frustrated by our lack of easing of restrictions. This is just the last few days numbers across the world, a select group of countries, not everybody by any means, but you can see that in some parts of the world, this is still accelerating. Half of Europe still has an accelerating pandemic. The Americas, lots of the Americas still have an accelerating pandemic. The US has finally got control of the only wave they've had. They didn't manage to have a gap between a first and second wave because they didn't manage the crisis. This is vaccination, same thing you've seen from Gideon with a slightly different list. I put you at the top of this list. I took off Gibraltar. It just felt too small for a comparison. The other one I took off, and they are done, is the Seychelles, but they have almost no people, although many of us, I think, would like to visit if we were allowed. And this is the Scottish position on our rollout. So this is what the Joint Committee on Vaccination tell us to do. Do it by age and do it as fast as you can based on supply. And you can see where we are. Some of you will perhaps be done. Some of you will be in this category. I'm in the 50 to 54-year-old category. I know it seems hard to believe. And we've done about a third of them already, and we're moving downwards to do all over 50s by the 15th of April, and then we will do all of the adult population by the end of July. And this is why we're doing it by age. So very quickly, it takes 14 vaccines to prevent 1 death in the over 90s, and it takes 40,000 vaccines to prevent 1 death in the over 50s in my age group. And then one final thing I want to do just before I stop sharing, and it's to talk to you about the lens through which we make these choices. And this may come up in the questioning. I'm very happy to be to talk about it. But today we had catchily titled the 4 Harms meeting in the Scottish Government, and it's got local authority people in it. It's got scientists. It's got the senior clinical advisors to the politicians. And we look at COVID through this lens. And it's important, I think, that we think of it broadly. Harm number 1 is the health harm, the harm from COVID, the death and misery from direct viral infection. The second harm is the impact the response has on the health and social care service. So what have you had to do to cancer screening? What have you done to your elective surgical waiting lists? So all the postponed care. What has it done to people who haven't turned up with chest pain or strokes? And the third one is social harm. That's schools, that's places of worship being closed, that's loneliness in elderly people who haven't had care home visits. And it's a really difficult thing to quantify, but it's massive. And it's all to do with the response to COVID, not COVID itself. And then finally, the raw economic harm from unemployment, business loss, GDP reduction. And we try and think of it in all 4 of those harms to get us through to the correct advice that we then give the decision makers who make those choices. So let me just go back to here, stop sharing and hand back to Gideon.
Thank you very much, Professor Leitch. Michael Livingstone, the floor is yours.
Thank you for inviting me, and thank you to everyone that's shown up, particularly those of you who are not close relatives of mine. I think you deserve extra credit. So I won't present with any slides. I'll kind of cover 2 things. Firstly, kind of who am I, why am I here? And then secondly, to talk a bit about the British approach. And I use that term advisedly because I will start off with the British approach and move on to the English approach. So I'm originally from Glasgow, and I am now a civil servant working for the British government in London as a deputy director in our COVID Taskforce, which is the bit of cabinet office that directly advises the Prime Minister and other ministers on the national response. And I've been doing that job since the 24th of March last year. So I showed up the morning after lockdown was announced to work out what it actually meant. I'm a civil servant, so I'm apolitical. I serve the government of the day, and I'm not a spokesperson for the British government. I say all that as a caveat up front because I'm not going to speak that freely. I'm not going to provide political judgments, comment on the relationships between the Prime Minister and the First Minister, etc. But what I can give you is a bit of an insight into the national response and how that's come about, because although I am not a scientific expert, I'm not a medical expert, I'm not an economist, my role is to bring together the inputs from all those people, and Jason will work with my opposite numbers in the Scottish Government as well, to digest that, turn it into advice to our ministers so they can make decisions on the national response. And that's what I've been doing for the last year, across a range of issues, but particularly how we turn things into law, because governments can do 3 things. They can say things, and that has an impact. A Prime Minister or a First Minister says, stay home, you might stay home. They can spend money, and that influences behaviour, and they can pass laws, and that influences behaviour, both symbolically and because you might be scared that you'll be punished. And I have contributed in particular to the third one of those, the laws that we pass, and in particular around social contact, so how we restrict social contact. And along the way, as a Jewish person working in the task force, I have contributed to kind of ensuring that faith issues at large are considered as part of this, whether they are relevant to the Jewish community or more broadly. And I've done various bits of engagement with ministers and so on with different faith communities, primarily in England, though sometimes it's opened up more nationally. So looking at how we can permit communal worship, looking at what the implications are around different weddings and the limits you put there and so on. So that is the first part of what I wanted to say, why I'm here. The second part, in terms of our response, this started off very much a UK response where early doors, the Scientific Advisory Group on Emergencies, SAGE, started meeting regularly back in January last year. That is a pre-existing group, even though none of us had ever heard of it. They met when Salisbury attack happened, but it's never met like this. And nobody had ever heard of its members before, and now they're household figures. So that is kind of the UK approach and how it has diverged, but broadly been in line. Where are we now? Jason's right, it's not great, but actually this lockdown has worked. All parts of the UK responded to B117, the Kent variant, and it may have been slow, but case rates are coming down, and they continue to come down at pace in all parts of the country. So it wasn't quite as bad in Scotland back in January, but an average of 1 in 50 people in England had COVID in January. So walk around, if you were allowed, you'd see somebody who had COVID. Now, the numbers in England are 1 in 270. In Scotland, it's 1 in 320. So you're less likely to bump into somebody that has COVID. And that's because of this lockdown. It has helped. There was a point in mid-February that the decrease in case rates and hospitalizations began to level out in most parts of the country. And actually, it's sped up again. So things have got better. We don't know why that is. And it has a number of steps, just like yours will have. And again, led by data rather than set dates. And we've announced a number of set reviews, and some of those will, I'm sure, inform actions in the devolved administration. So a review of social distancing. When can you hug your mum? My mum doesn't worry about that. She's not the hugging type. Where certification, where will we have restrictions where if you have been vaccinated or have a negative test, you're able to do stuff. You've already got that in Israel with your green card. Large events, when will we have people back in stadiums? Are Scotland fans going to get to see England at Wembley in June? And global travel. So at what point are we going to be able to open up for international travel, and what's that going to mean? So we've got a roadmap, we've got those reviews, and they will broadly align with what happens in Scotland, though obviously it's going to be in its own way as it has been throughout this. So that's kind of my overarching insight. I'll pause there and look forward to answering questions.
Thank you very much, Michael. I'd like to hand over now to Professor David Katz. Please go ahead.
Thank you very much, and thank you for inviting me. And just to reassure Jason that the Jewish Medical Association, which is UK, provides elective bursaries for medical students from the UK to go and do work in the Nazareth Scottish Hospital. And we always call it the Scottish Hospital. I've never heard it called the English Hospital before in my life. So, you know, kind of it's a great idea. The other thing is that some of you may be a little bit confused by Gideon's introduction. Maybe I should start off by introducing the immune system, because as Professor of Immunopathology, that's the one thing I'm used to having to do. And many of my students always say that this is about the most complicated part of the medical course. So this is just to warn you. But what happens with the immune system is that it's a good thing. It's a very good thing because it protects us against invaders like viruses and like bacteria. And but you have to be introduced to those. And it transpired in the early 1970s that there were special cells that did this, that were expert at this, were better at this than other things. But how did we know they were better than that? Because we had to measure things. And the things that we measured, and this is just to familiarize you with things that become common knowledge today, but we tend to forget, like antibodies, like things that certain kinds of cells called B cells make, and they make them in response. And the antibodies, we've learnt over the years, are made in different kinds of ways, but they are antibodies that are specific for different kinds of things. And they're different kinds of antibodies. There's quickly made antibodies, there's slowly made antibodies. And so that's one aspect. But the other arm of that is that there are also other factors that are produced, soluble factors, other things that antibodies, that like antibodies, circulate in the bloodstream and are produced as part of the response. And some of these are called cytokines, some of them are called chemokines, but that's the general idea, that there are other soluble factors. But then there's also another major component, which is the response of what are called T cells. And the T cells may have two, broadly speaking, different kinds of functions. T cells may help other cells to make antibody, they're helper T cells, or they're T cells that are so-called cytotoxic. Those T cells kill cells, particularly cells that are virally infected. Now, this creates a background for you. This creates a background for you that we've got this disease. One way of looking at this disease is to look for the virus, and the other way is to look for the response to the virus, and to check as far as possible as you can the specificity of the response to the virus. And those rules remain the same, whether you're talking about the virus itself as coming in real life, or if you're giving something, you want to boost the response, the vaccine, in other words, you look for the same things. You look for antibodies, you look for soluble mediators that produce, you look for T cells. Now, we're all hung up by antibody levels. Antibody levels has gone into common parlance, but one has to remember that the antibody levels don't just come out of nowhere. They're actually part of a system. And one of the features why there's what's called immunopathology is that sometimes the immune system is a good thing because it's getting rid of the virus, but that it goes into overdrive. And one of the probably prevalent hypotheses at the moment is that the serious injury that happens and the serious lung disease that happens, and maybe even kidney disease and possibly even other areas, that serious disease is because it's immunopathology, because the disease, the response, as it were, takes on its own momentum. And you get lots and lots and lots of these cytokines, sometimes called a cytokine storm, which is what's responsible for your injury. Now, that's the background of the immune system, which you have to bear in mind when you look at what's happening and the problems of what's happening and the good things that are happening as well as the bad. And in my particular instance, just have to remind you that I'm not a clinical doctor. I don't look after patients myself, although I'm medically qualified. I'm the kind of person who works in the laboratory on all those kinds of things and tries and works out what's gone wrong in those systems and how it can be improved. So that's a background. Now let's take another bit of the background and say that all of you know about vaccinations and immunization. All of you know about them. And you know that there's a vaccine for polio, and you know that there's a vaccine for tetanus, and you know that there's a vaccine for smallpox. You know all that. But what you don't often realize is that each vaccine is slightly different. In some vaccines, you give a little bit of the organism. The famous one, smallpox, that kind of vaccine, you give an organism that resembles the one that causes smallpox. Some vaccines, like the measles ones, are a kind of attenuated form. Some vaccines consist of a protein. Some vaccines consist of an encapsulated protein. Some vaccines require something to boost it along the way. So that's why we don't all start off life, we all know about childhood immunization. We don't start off life having a whole battery of immunizations at the side and get it all over with. We have them at different times and different stages. We know also that there are some viral infections, and you all know this, but you don't think about it very often, that there's no vaccine yet. HIV is the classic biggest example. Now, HIV, the lack of a vaccine is interesting because one of the reasons suggested is that the virus actually varies, it changes, and it changes in various kinds of forms. And I'm old enough, and probably old enough, the only person who remembers the days when Scotland at the beginning of the HIV pandemic, was it a pandemic? Maybe not by the criteria we'd given, but the HIV experience, that the Edinburgh and Glasgow were not too far apart, but the variant of the virus that was in Edinburgh was a different variant of the virus that was in Glasgow. So there were two different types of the same virus. So that's an example. We look here today about the variants, the mutants that occur. This is what viruses do. They do these kinds of changes. And but the ideal would be to achieve a vaccine. And again, vaccines have changed and evolved. And the big change in one was, for example, the hepatitis B one, where you used for hepatitis B what was called a recombinant, a genetically modified, genetically designed, or not genetically modified, genetically designed. But that was good for hepatitis B. And in the early days of hepatitis B vaccination, we used to actually go and test people every year because we didn't know how long the immunity lasted for. And we insisted on 3 doses. And then gradually we discovered over time that those 3 doses weren't necessarily appropriate. So you see, all the noise that we're seeing now around the vaccine, around the disease, all of it is part of the past of the vaccination kind of programs that have gone in before, but the public hasn't really noticed it. It hasn't reached the public domain in the way it has here. What is dramatic, and what in all this conversation that I've heard from Michael and Jason, we're accepting the fact that you can do things like identify cases by looking for viral fragments. We accept automatically that you can test whether a person has had it or hasn't had it, and you can check on the antibody levels. And not only that, but within 1 year, you can produce a vaccine that's actually quite effective. And underlying both the test and the vaccine are the remarkable achievement that we can actually get the sequence. We actually get the actual building blocks of the actual virus and determine it and determine where the mutants are. It's incredible that this has happened within a year. And it's an achievement of biomedical science and a cooperative international achievement of biomedical science that is absolutely remarkable. And we can be very proud in Britain and in Israel of the fact that we've contributed to this in different kinds of ways. The British genome sequencing is absolutely remarkable. The way that the Pfizer vaccine has been distributed and the information gathered in Israel is absolutely remarkable. It's a totally new kind of concept. You know, I worked in Israel in the dim distant past, about nearly 50 years ago now. And I actually, one of the first things I ever did was in terms of research, was to identify a case of a disseminated tuberculosis vaccine. And unfortunately, a child died. And we were unable, we did a variety of tests. We were able to discover the reason, but the child unfortunately died as a result of this. Now that's incredibly rare. Vaccine hesitancy is a major problem, and I hope we're going to be asked questions about that. But it was incredibly rare occurrence. It took nearly close to 40 years for somebody actually managed to work out what exactly was wrong with that child. That there was something, that there was nothing wrong with the vaccine, but there was something wrong with that child's receptors, the way the child responded. The child was unable to respond to the vaccine in a normal kind of way. It's incredibly rare, but it shows you the time lag that happens in investigation of these things. So we actually, with regard to the vaccine, we are in a remarkable position also, because the vaccine is not the same as the previous kinds. We're not really using the virus or extraction of the virus. What the advance is that we've had this huge success in creating the RNA vaccines, and which people like myself have been trying to introduce RNA in that kind of way into cells for close to 30 years. And we've never succeeded in doing what has been done by the Pfizer and Moderna vaccines in introducing RNA and getting the protein made in such a way that it will produce an immune response. Now, in the part of what I do is work amongst the faith communities. And we've heard a little bit about the faith communities, and again, maybe there'll be questions about this. And there has been an apparent higher mortality amongst Jews in the UK. That questions about how you count that and how you monitor that are important. But the medical groups from the faith communities in the UK have got together and discussed these kinds of questions. And one of the things that we're proud of as a group is that as soon as the vaccine was approved, we did a joint statement between the faith communities, pointing out that this was safe, important, and critical that people adopted. And that is the position of the faith medical communities in the UK. It's interesting that we wrote this together and then topped and tailed it. And the topping for the Jewish community was that, in fact, one of the first faith communities and one of the first religious people to adopt smallpox vaccine was a rabbi in London in the 18th century, and 2 of his children had died of smallpox. He heard about this new development that you could actually immunize, or what they would call immunize, and he wrote saying that the Jewish response to this should be to adopt this immunization, this new form of treatment, because it prevented people from getting ill, and it prevented their families from getting ill, and it saved lives. And I think I'll stop there and take questions.
Thank you very much, Professor Katz. We'll come on to questions shortly, but first, I'd like to give Professor Eyal Leshem an opportunity to give his introductory slides.
Yeah, good evening, and thank you very much for the invite. I will start by saying I have a special link with Scotland. I was fortunate to take my diploma in tropical medicine hygiene at Glasgow University, where I took the course and sat for the board exam, and I would love to go back to Scotland soon as the skies open. I will try and spend a few minutes in sharing Israel's experience with rolling out the vaccine and the kind of impact we saw, which I believe Scotland and the UK are lagging a few weeks behind us. You've already heard about the demographics of Israel, but in a nutshell, we are a young country of 9 million. Parity is very high, 3 per women, which is the highest in the Organization of Economic Cooperation and Development. Healthcare expenditure, however, is one of the lowest. We spend only 7% of our GDP on healthcare, which puts us on place 28 in the OECD. And despite that, our life expectancy is longer. You could argue it has to do with Mediterranean diet or other factors, but we relatively do well relative to other countries. Healthcare system in Israel is completely socialized. We have a national healthcare law, which means that every legal resident is entitled for full healthcare with a very low copay. Coverage is universal, regardless of taxpayer status or employment status simply by being a legal resident. And there are 4 public sector healthcare funds which compete over us, the citizens. So you are able to move between the funds. So providing higher quality means they have more people in their fund, and they all use a full electronic medical record. And what this means is that if I sit in Sheba Medical Center emergency room and I have a patient from the community showing up, I can see all their medical data, including previous doctor appointments, operations, imaging, or lab tests that they done in the community. It's all available to me in all hospitals across Israel. Currently, you heard from Gideon, we have, so a nation of 9 million, we have over 800,000 cases and nearly 6,000 deaths since the beginning of the outbreak. And we're seeing the end of our 3rd wave. The first one occurred around Purim and Passover exactly a year ago with a very effective lockdown. Second was really around Rosh Hashanah, and the 3rd one right after Hanukkah, which is ending now. All were responded by complete lockdowns. Moving to immunization, the first Israeli citizen to be immunized back in December 19th was the Prime Minister Netanyahu. This had a good public health communication message, because seeing your Prime Minister get vaccinated really delivers a confidence in the vaccine safety and efficacy, as was reported by the randomized trials, and there was good compliance with the vaccination recommendations. And the way we did it in Israel is there were 4 tiers. First, really older Israelis aged over 60 and healthcare and people with chronic illnesses. Moving in mid-January, 3 weeks after the vaccine was rolled out, we moved to all persons with chronic diseases. A couple of weeks later, everybody aged over 50, and then we also started immunizing school children aged 16 to 18 so they can sit for their matriculation. And finally, 6 weeks after we started, the vaccines were open to all Israeli citizens. And you've already seen how well Israel has done coverage-wise. So by about a month ago, we had more than 80% of persons over 60 years old fully vaccinated with 2 doses of the vaccine, with lower rates for citizens under 60. But this changed. So the situation as of today, we have 5.1 million who received 1 dose and 3.6 million who received 2 doses. And you really want to look at the green boxes in this table that tell you that 86% of Israeli citizens aged over 50 are vaccinated, and 3% more recovered from the disease. So they are also probably protected, which leaves only 264,000 people above age 50 that are not vaccinated yet or not protected yet. How did this impact the illness levels? What you see in these panels are disease number of cases by date. And what you see on the dotted vertical line is the date in January where we entered our 3rd lockdown. And about a week after we entered lockdown, you see a decline in the number of cases, but you see 2 curves. One curve is blue, and that gives you citizens aged over 60. And the other is yellow-orange, which gives you younger citizens. And while citizens over 60, the number of cases and the number of severe cases and hospitalizations continued to drop into the end of January and beginning of February, those in younger persons started to go up again in early February, and that is because lockdown was not observed very orthodoxy, I would say. And the explanation to why persons over 60, the number of cases continue to drop, is on the bottom panel, where you can see the proportion of citizens over 60 in the blue that are vaccinated, and you see how rapidly we reached over 80% covered with 2 doses compared with the left bottom panel where you see coverage of persons under 60, which was still low. When the Ministry of Health looked at proportion of persons who are fully vaccinated that got infected by end of January, that saw that a very low proportion of persons, you see on the left the number that are fully vaccinated and the number that contracted COVID, and you see that about 500 out of 740,000 persons aged over 60 got the disease. But much more importantly, you see that only that 480 of these 500 that got infected were not hospitalized. So you have older people that get the disease, but they do not develop severe disease. They don't need to be hospitalized. All they have are mild symptoms, or maybe they are asymptomatic. And this was really one of the first signals for the very high effectiveness of the vaccine. So back in about 4 weeks ago, we were able to publish very early data from Shibal Medical Center in the Lancet journal showing that a single dose of vaccine was very effective, about 80%, 85% in preventing symptomatic illness, symptomatic COVID. And these were very early real life evidence. So we knew this from the vaccine trials, but nobody knew how well the vaccine works in real life. And that was the first publication to show this on Shibal Medical Center health workers. And soon after that followed the large publication from our largest HMO, largest healthcare fund, Clalit Services, which showed that by 1 week after the second dose, the vaccine prevent over 90% of severe cases. These were all really comparing vaccinated against unvaccinated or versus unvaccinated people that were correlated or matched by age and by place of residence and background illness. So you could really see the vaccine worked across age groups with very high effectiveness and even in people with background illnesses. This is a very effective vaccine. And to conclude, Israel was very lucky to reach a very high coverage of population at risk. We had some challenging populations, and our challenge right now is to get higher coverage in the younger and healthier. And you can see on the right what this challenge needs to be addressed in a culturally adjusted method. So for example, to get young people, you want to make it, many of them do not oppose the vaccine or are not anti-vaxxers, they are just hesitant. You need to make it easier. So the Magen David Adom, the EMS, emergency services, will go to restaurants and bars and give a free beer to any youngster who gets immunized. And they are able to get some people vaccinated like that. In January, the most predominant variant was the UK variant. We can call it the Kent variant. That will also work for me, but in Israel, we indeed call it the UK. So which tells you that the vaccine is effective in real life against the UK variant. And our effective analysis showed very high effectiveness after the first dose and even higher effectiveness after 2 doses. And with that, I will hand back speak to Gideon, and thank you for the opportunity to present the data.
Thank you very much. I should just add, if we're talking about culturally appropriate reasons to get vaccinated, in the ultra-Orthodox communities, people were offered a free bowl of cholent, or chamin, as we call it in Israel, rather than an alcoholic drink in Tel Aviv. So, to each community as is appropriate. So thank you very much for that. We're going to proceed now with questions. These are questions that came in from people registering for the event. So first of all, a question for Professor Leitch. And then after he responds, any of the other panelists are welcome to disagree or comment. Regarding vaccinations for pregnant women, expectant mothers, Israel is recommending them, but the UK is not. Could you provide any insight as to why that is?
That's not quite true. We are recommending them after a risk assessment of the pregnant women. So we're asking there to be a conversation between the vaccinator and the vaccinatee. So we're very comfortable with the safety profile of the vaccine, but there haven't been big trials in pregnant women. And that's true of many, many medicines and many vaccines. So we're just being slightly more cautious in that community, particularly because women often, when they're pregnant, are worried about taking any medicines or vaccines because they've been taught that that's maybe not what they should do. So we want individual risk assessments done. We don't line people up and inject them in a big row. We have conversations and consent with each one of them, whatever's wrong with them or whatever joy they're experiencing in their pregnancy. So it's about individual conversations rather than a ban on vaccine in pregnant women.
Okay, thank you very much. Any other panelists have anything to add?
Yeah, I would add a little bit from the Israeli experience, several things. First of all, we need to bear in mind that COVID could be a very severe illness in pregnant women as other viruses cause, as we know from influenza. And we've had, I treat patients, we've had several very severe cases. We've had mortality in pregnant women. Remember, pregnant women have kids that go to preschools and kindergartens in Israel and bring back the disease to their mothers who are pregnant. So in Israel, we felt that since this is not a live virus, this is an inactive vaccine, and the physiology shows that makes sense that it's very safe for pregnant women, and we went ahead and recommended it to pregnant women. The other thing we need to bear in mind is a special discussion needs to take place early in pregnancy, because during the first trimester, miscarriages are very common as a natural course, regardless of the vaccine. So women that do consider to take it early in their pregnancy need to know that although we think the vaccine is very safe, there's no reason to think it isn't safe. Miscarriages are common during this time. We don't have a signal in Israel showing that the vaccine is not safe for pregnant women. And because disease rates were so high during January and February, we felt that the recommendation for pregnant women should hold over.
Just add very briefly, the reason why it's kind of not a given, and equally why the approval says that it is unknown what effect the vaccine may have on fertility, is not because it is unsafe for women planning to get pregnant or women who are pregnant, but because the trials that took place last year didn't include pregnant women or women expecting to get pregnant. There are now live trials in the field with both those cohorts. So there'll be greater certainty. And as Jason says, the vaccine is also being given to pregnant women. We will know more, but that is why the medicines and healthcare regulatory agencies kind of report on this had those caveats in it.
Okay, thank you all. Next question, which I will direct to Professor Katz. What is the reason to believe that the efficacy of the Pfizer vaccine is not affected by a 9-week gap between injections?
Well, I think that's maybe more of a question for Michael. But as far as I'm aware, the original Pfizer approval gave a shorter period, and that was the original decision along the same kind of lines as we've heard about pregnancy, that it hadn't been tested for extended periods of time. It may be okay to go on to 9 weeks. It may be okay to go on to 12 weeks or longer, but it's just not been shown and has not been proven in quite in the same kind of way. Now, the Israeli experience that you've seen suggests that there may be longer immunity as a result of the Pfizer than was at first thought. But at the moment, we still are in the situation where the Pfizer approval was for that period, for the 42-day period.
That's not strictly true, Professor Katz, if you'll forgive me. So that's what the drug company said. That's not what the regulator said. So in the UK, the regulator looked at the drug company data, the real life data from Israel as it came in, because Israel was first, and our own data as it happened. And what we have in the UK is a committee of boffins. And those boffins are the UK-wide experts on vaccination. Well, who better than them to give us advice on vaccination? You wouldn't certainly look to me. I'm a neurosurgeon, not an immunologist. So the boffins looked at the data and they said, we think the best way to protect the country is single dose vaccination and 12-week gaps while supply comes in. Now, if they'd had 9 million doses of vaccine for Scotland on the first day, they may not have given that advice. They may have given different advice. It turns out the more recent trials, Israeli in particular, but also some Brazilian trials and now some UK trials, turns out they were absolutely right. And the protection from first dose is high 80s and 90s from either vaccine that we have available to us just now, both AstraZeneca and Pfizer. And the second dose principally elongates your immunity rather than gives you a few extra percentage points of immunity. But those percentages are kind of abstract for normal people. I mean, what does 85% protection mean? It's meaningless, really, for most people in the real world. So,
yeah. Sorry, I'm just saying that the question of the individual versus the national data, I can see from a national point of view why the JCVI, the committee you're referring to, would make the recommendation it made. But the actual hard data was still the stuff that Pfizer had submitted. So I can understand that there are 2 points of view. That's all I was trying to get across. I wasn't trying to get across that JCVI got it wrong. I was going to say there were 2 points of view that for the population.
The bit I was contesting was not that. The bit I was contesting was that the regulator, the data had said 3 weeks. The drug company had said 3 weeks, and that's what they asked for approval for. We gave approval for 12 weeks.
Yeah.
Okay. Thank you. Question for Professor Leshem. Have you seen a change in the pattern or the severity of clinical symptoms now that the British or the Kent variant has become dominant in Israel and the patients are now becoming younger as a result of vaccination?
No, generally speaking, we don't see a change in what we call virulence. So it is very rare to see different virulence for the same virus. Sometimes you can see very mild changes, but for COVID, we've not seen a more violent variant. They all produce approximately the same incidence of mild, moderate, and severe illness. What we are seeing now is when the older population is fully or nearly fully vaccinated, in hospital, in our intensive care unit right now at Sheba Medical Center, we have almost strictly persons aged in their 30s and 40s, unvaccinated. All of our intensive care unit patients are unvaccinated. Younger people contracted the disease. Many or most of them have some risk factor, but not a major immune compromise. They may be obese or slight or overweight. They may be smoking or have a hypertension, diabetes, any of the risk factors in younger, and they suffer from very severe disease. Right now we have 6 patients. We've put our 7th patients on ECMO, on heart-lung replacement machine today at Sheba, which is a huge burden, all very young, healthy people. So I urge, once you have the opportunity, once the younger population has the opportunity, I urge them to line and get the vaccine. And I also want to reinforce what Professor Leitch here said. When a drug company says 21 days interval, it's why that's how, the reason is that's how they put the clinical trial, to make sure it works. But I've been reviewing manuscripts from the UK showing excellent effectiveness, real life effectiveness of a single dose. And I think this really reinforces the policy decision that was made to protect as many people as possible with a very good protection instead of protecting half the population with perfect immunity. It makes sense on the public health, but it certainly did not diminish in a substantial way the protection for a single vaccinee.
Okay, so if there's no further response from the panel on that, I'll proceed to the next question. This is for Professor Leitch. What are the ethical and practical issues to be considered when dealing with health workers or care workers who do not wish to be vaccinated?
I mean, they're fairly obvious. We only have one example in the modern healthcare system where we insist on vaccination. And when I had a proper job, I wasn't allowed to operate without a hepatitis B vaccine, and unless I was exempt for some reason. And most countries in the world have that. The only global example of that for non-healthcare workers is yellow fever. And anybody who's been in and out of yellow fever countries will know the WHO-led yellow fever certificate. My view, and it happens to coincide with the Scottish Government's present view, although we may take a different view in time, is we should spend our time in persuasion and spend our time in positive descriptions rather than spend our time in law and mandation. And most of the literature would suggest that's correct. That's where you should spend your energy and spend your money and spend your clever people. Now, it may be in the end, we have to do something for the tail, but actually most of your energy should be spent in outlining the positive elements and the positive benefits, both for you, your family, and the broader community. There's a fantastic website called the Vaccine Confidence Project, which is all about the anti-vax community. And their summary is surround every community with the correct information in their culture. So if that's Gypsy travelers, or that's the Bangladeshi community in East London, whoever that might be, don't engage with the anti-vax community. Don't even talk to them. Just surround each community with the correct information. TV adverts, interviews, trusted voices that they believe rather than the white guy who comes in from the middle-aged white guy from Glasgow. So use trusted voices in whichever community it happens to be to spread the good message about vaccination. And I think that's true of health and care workers as well. Our social care workers were very horribly targeted by an anti-vax campaign. We think that probably came from overseas, and we had to put in place some special communication. So I did a lot of webinars for social care workers, and we got the numbers up really high. So now well over 90% of our social care workers have taken the vaccine.
Thank you. Okay, so if there's no further response on that, next question, this is for Professor Katz. Can you give us any insight into why many parts of Africa have got off so lightly with the pandemic? Has there been a related virus in the past which has given them some kind of immunity?
This will be total guesswork because I don't think anybody knows the answer, number one. And number two, we don't know what the data collection is across Africa. Africa is not just one country and it's not just one locality. And it may be that the incidence is higher than in other places. So, or is higher than it appears to be. With regard to the question of why certain countries have had this or not, there is, as yet, as far as I'm aware, no evidence of any kind of genetic susceptibility thus far clearly shown. And there's no evidence and there's evidence that health inequalities do affect the disease, as we've seen and we've heard in Britain. But again, there doesn't appear to be any evidence that there's the gradient of health inequalities in Africa, but it's an unknown. So I'm afraid that would be pure speculation. The question of previous virus exposure and exposure to a previous similar kind of virus, I think that one would know that from the known sequencing of the virus and as we know, the known sequencing of the virus, the sequencing of the virus is excellent in South Africa, and they've been working with the British on this, and the sequence of the virus appears to be very similar. So there doesn't appear to be anything like a different virus that's cross-reacting in some kind of way and getting a cross-reacting immune response.
Thank you. Any other response?
I think the other tragic element is I agree completely with Professor Katz around the data collection and the Southern African news. We do have some data from North Africa, from Egypt and Tunisia and some other countries in the north. The other tragedy is that in sub-Saharan Africa, many of the high-risk group are already dead. So I hate to have to say that so bluntly, but they often die of other communicable disease prior to reaching the age groups that contain Israel's and the UK's really high mortality in our over 70s and over 80s.
I was going to make a similar point. I would say three things on this. One is more people have probably died in the developing world than have been counted. They don't test as often. They'll have counted them as deaths from other causes. So their stats are not necessarily representative. Two, we know outdoors good, indoors bad, and people spend a lot more time outdoors with a lot more ultraviolet light. And that's a good thing, and will have mitigated transmission a lot in those warmer countries. And the third point is as Jason said, the main comorbidity is age, and they have fewer old people.
Okay, thank you. Question for Professor Leshem. Now that Israel has vaccinated almost all of its at-risk population, what should we do about children who are generally low risk and can't yet be vaccinated? Should we allow them all to get infected naturally to gain natural immunity? Or should we continue with testing and self-isolation and closing school classes when a case is discovered?
Yeah, that is a bit of a challenging question. I will begin with, again, saying that physiologically, it makes perfect sense that the vaccine is very safe, at least for older children aged over 12 or aged over 5, probably also for younger ages. This is now being tested by several vaccine manufacturers, and we will see more data emerge late 2021 or early 2022 about younger age groups. In the meantime, what we did in Israel is we decided to vaccinate children with risk factors for severe disease. These are children that suffer from severe illnesses or from immune deficiencies. And to our judgment, COVID risks them more than any potential risk of the vaccine. If they get COVID, they are in real death risk, whereas if they get the vaccine, it's a theoretic risk for maybe untested adverse event. And we vaccinated more than 500 children without any adverse events. So this will provide some real world data about vaccine safety in these younger kids and perhaps also effectiveness. And I really hope by the end of 21, we will have also randomized clinical data supporting vaccine safety and efficacy in kids, and we can add the vaccine to our children. In the meantime, the real question is, do we still need to put in quarantine whole classes and whole capsules that were exposed to a single child? We know that the illness is very mild in these kids. We know that the risk of once we have all at-risk population protected, the risk of severe disease in their contacts is very low. And we know there is substantial damage from putting a young child in 2 weeks in a closed room or with a family member. There's economic damage to the family, but there's also mental damage to the child that needs to be also isolated from school. So this is the discussion we're heading to. Before even vaccinating the kids, do we really need to put them in 2 weeks of quarantine, even if they were exposed? Over.
Okay, thank you. And I also am interested in that question, having just had one of my own children spend a week in her bedroom as a result of contact, and she tested negative. So we're going to end with one final question for Professor Leitch. And perhaps this is in some sense a summary question. If you knew then what you know now, how would you have changed the UK response to the pandemic?
It's an excellent question, and I think we'll spend some years thinking about it. I remember a conversation quite early on with Chris, who's the Chief Medical Officer in England, and he and I had known each other vaguely, but not well. He's a neurologist and I'm a neurosurgeon, and we landed in the seats we sit in during a global pandemic. We hoped we wouldn't, but here we are. And he said that he thought in the end, most countries in the world would end up with the same excess mortality. And as the year has passed, that hasn't proved quite true. But as we see pieces of Central and Eastern Europe rise and the UK fall and other bits of the world do slightly different things, I think he might well be right in the end. That what we did was to save our health service from being completely overwhelmed, as happened in Northern Italy, as Michael referenced earlier. But I think we might end up across Europe and Israel and other parts of the developed world with a very, very similar pandemic in the end. It'll be bumpy in different ways, but it will look very similar. I think there are lessons to learn about care homes and the nature of our social care system. We have a mixed system of provision, and they were responsible for their own PPE provision. We had to take that over. We've also done the vaccination in there. The health service, the government has had to, across the whole of the UK, has had to step into that market and change it. There is an argument about date of lockdown and what that lockdown should be. Most countries that have acted fast and hard have, in that medium-term response, had a lower level of COVID mortality. Now, where we end up in the four harms and the four mortalities that Michael illustrated earlier is still yet to be written, and that history will take a long time to write. But I imagine the next bit of my career is public inquiries, and I can hardly wait. So today, my affidavit, my first ever non-clinical affidavit, is at the High Court in Edinburgh about a judicial review around places of worship opening, and we haven't touched on that here. And I imagine my life for the next little while is going to be along those lines, about what evidence you had, what advice you gave, and then what the decision makers did.
Thank you. Well, at this point, I'll say thank you very much to all the panelists. There are many more questions I have, and there's been more questions coming in that unfortunately we won't have time for.